So I want you to understand that your role as the nurse, as the long-term care nurse, is to recognize that incontinence impacts quality of life. And you really are the messenger to the rest of the staff in reminding them about that, but also teaching the CNAs. And also being able to talk to the residents that you recognize that this is a quality of life issue. So this is really important. It's also your role or your job to identify which of the residents are at risk for developing incontinence and be able to put prevention strategies in place. So if someone needs assistance to, for toileting, ensuring that they have adequate staffing to help with that, or if there's some environmental issues related to lighting or the physical layout of the bathroom, whatever those are, to be able to really address that. But also if they're prone to constipation, and we'll talk about these other risk factors, being able to anticipate or proactively address this to keep the resident as continent as they're able is really our goal. Now, in the same light, it's just as important to identify residents who already have incontinence and to really try to figure out what type of incontinence they have and what kind of care plan will work for them. And then one of the things that gets left out a lot, and that's why I want to emphasize this, is it's really important to be able to talk to residents and their families or their caregivers about the issue. So being able to, let them know that the bladder does change with aging, and that there are risk factors that will make it more likely, but also being able to reassure them that there are management strategies that you're willing to put into place and that you're willing to implement, and that you'd like their feedback on their success would be a really important strategy. Also being able to provide information about further evaluation and treatment options. So, in those situations where you think someone could benefit from a medication for their incontinence, or perhaps they need to be fitted for an incontinence device that supports the pelvic organs, which we'll talk about in a minute, this would be a really good example of where you could make those connections for the resident and caregivers. And then again, making referrals as needed. So how do you identify at-risk patients? Well, you start by asking them. And one of the things that I've worked really hard at my sites is getting questions related to incontinence on the admission form. It's not very helpful to have a question on the admission form that says, do you have urinary incontinence? I always talk with my students about the fact that that's sort of like asking someone, am I a victim of domestic violence? Both of those situations can be embarrassing, and both of those situations can be difficult for people to answer, honestly, and so it's not very helpful. We already know that the correct answer should be no, and so if you're yes, there is a stigma that's attached with the way you've asked that question. However, you can add questions to the admission assessment that have been shown to encourage patients to report their incontinence. And so, asking things like, are you having any problems with your bladder? Do you ever lose urine when you don't want to? One of the things I always say to the residents I see is, so tell me, how's your bladder working? And usually they tell me too well. But do you ever leak urine when you cough, laugh, sneeze, or exercise, or I often say when you get up from a chair? And are you wearing pads to protect your clothes? And do you ever leak on the way to the bathroom? So even if you couldn't add all of these questions into your admission assessment, if you could even pick 3 that you think would be helpful, that would be a definite start in being able to begin this conversation. Now, as someone's admitted to your facility and as they're being evaluated, not only on admission, but again on a quarterly basis as a part of the MDS or the minimum data set, it's really important to be able to identify risk factors. And so I want to take a couple minutes and go through this. There are lifestyle factors that will increase the risk of urinary incontinence, and these are related to diet and bladder irritants. And I've mentioned to you things like alcohol, caffeine, and NutraSweet or aspartame. Many people have sensitivities to these, and it can increase frequency and urgency in particular. Certainly a low-fiber diet contributes to constipation, which can also contribute to issues. And then also think about within that their fluid intake, because many people try to self-manage by cutting back on their fluids, and I get that. That certainly, makes sense, but it doesn't work very well, because what happens instead is that the urine becomes more concentrated. It starts to act as a bladder irritant and causes urgency and frequency and contribute to the incontinence. It also puts them at risk for urinary tract infection and constipation. So we don't want to be recommending fluid restriction on a regular basis. There are times when fluid restriction is really helpful, and one of those times is, a couple hours, 2 to 3 hours before they go to bed. Or what I always tell people is, after your evening meal. If you want to cut back on your fluids, then that's a good time. So again, just thinking about that. Certainly people who smoke are going to be more at risk for bladder issues, and not only is their risk of bladder cancer increased as well as other types of cancer, but the nicotine can act as an irritant on the bladder, and the coughing that frequently accompanies smoking can contribute to symptoms of stress urinary incontinence. Weight, we talked a little bit about that with the truncal obesity, but we know that you don't have to lose all of your weight to have improved benefit in your bladder in function. In fact, research tells us that even as little as a 5-pound weight loss will improve bladder control for those patients who are struggling with stress urinary incontinence. So I think it's important to talk about that. And then functional changes or mobility issues, we've kind of addressed already, but being able to really be supportive of ambulation and ADLs to the extent that somebody is able is a really important thing in preserving that quality of life. Constipation, we've talked a little bit about. I've alluded to the fact that being female certainly increases your risk. Again, it's the loss of estrogen, having gone through menopause. Many of our residents have had children, and we know that one of the other areas where women, or times when women are more likely to experience issues with incontinence, usually stress urinary incontinence, is around childbirth. But for the purposes of our elder or older women that we are seeing in the nursing home, think about this loss of estrogen, this hypoestrogen state, as being a big factor in contributing to urinary incontinence. And then for men, prostate enlargement or hypertrophy, and even men who've had prostate surgeries, the way that the surgery is done with the retractors, it often stretches the pelvic floor muscles, and yes, men have pelvic floor muscles as well as women, and so they're prone to stress urinary incontinence as well, and this is a good example of where pelvic muscle exercises could be really beneficial. Medications will contribute, and there's lots and lots of lists. All you have to do is Google medications that will cause incontinence, and you can't believe the list that comes up. But the most common ones have to do with the diuretics. We talked about muscle relaxants, we talked about sedatives, but I also look for things like antidepressants, antipsychotics, certainly things like warfarin. They all have anticholinergic properties that, when put together, can certainly cause changes in bladder function. Cognitive impairment, we talked a little bit about this also with the transient incontinence, but certainly dementias and delirium put people at risk for incontinence, as does neurologic disease. And we see a lot of residents who've had strokes, and we have a number who also have Parkinson's disease and multiple sclerosis. So very common neurologic conditions that can impact bladder function, as can diabetes and heart failure arthritis, and then depression and anxiety. All of those have a direct impact on continence status. So having those as well managed as possible will also help with the management of bladder function. So we talked about on admission questions that would work well. Also, as part of your history, not only are you interviewing the resident, but also the family. And then one of the things that's really important is this transitional care. So being able to get information on bladder function among the many things that you want information on during this handoff, if they're coming from another setting, is going to be really important, because one of the things that frequently happens is that our frail elders have catheters in until they're due to be discharged, and oftentimes information on when the catheter was taken out, how long it was in, whether or not they've reestablished voiding is not communicated. And so again, this can be kind of a high-risk situation, high-risk time for patients for being able to manage their bladder function. And then certainly any medical records that you have access to are helpful to take a look at. Now, you're also going to be assessing continence status as part of your weekly nursing summary, and this is usually documented in the chart by whoever is the primary nurse that day on the day that it's due in your facility. And then the MDS quarterly review has a whole section on bladder function. It's section 8 on the assessment tool, and if you haven't had a chance to look at it, I would ask you to talk to your MDS coordinator and have that nurse show you what the MDS tool looks like, and particularly take a look at section H. Now, ongoing nursing assessment is going to focus on certainly what we've talked about, any early identification of a change in continence. So reassessing any changes in continence with a review of risk factors and history, and getting a bladder diary is going to be an important part of that process. And then being able to adjust or confirm the management plan should be something that you're documenting in your facilities. The goal here is to achieve as much continence as is possible for that resident. So we have a lot of residents that with the right toileting plan and assistance, they're able to stay dry most of the day, and they might be more prone to having a wet episode at night or early in the morning. But that's a significant improvement over being wet several times a day when they didn't have assistance with toileting. So again, I share that with you as a very common example of how we can achieve a significantly improved continence with some of the behavioral strategies that are certainly within the cadre of tools that nurses can implement and recommend. And again, the goal is to support as much quality of life and dignity as possible. And it's going to be important for you as a team leader to really foster communication with the CNAs, because they're going to be helping you with the care of these patients. They're going to be intimately involved in toileting as well as maintaining, the perineal hygiene, and so it's just going to be really important that you've got good conversations going on with them and that you're able to teach them what you're learning as well. Talking to the family and the resident, letting them know, having an open communication so that they can let you know what is and isn't working, but also this communication between nurses from one shift to the next is also an important thing. So objectively, there are things that you can do to determine voiding pattern, the frequency, and the amount. One of the ways that we do this is with a bladder record or a bladder diary. And there's lots of different tools that exist. And again, this is another area that if you want to Google bladder diaries, you can find many, many bladder diaries. Many facilities have already chosen bladder diaries or have had bladder diaries recommended to them by the state surveyors. And so one of the things that I want you to do as part of this learning module is to take a look at what is being used in your facility. And I want you to take a yellow highlighter and take a look at a couple who've been completed and highlight the wet episodes with the highlighter so that you can start to look at so that the pattern and the frequency will stand out for you and you have a sense of what kind of toileting plan might fit for this resident. Now, we do rely on the resident and the CNAs to accurately complete these, more so the CNAs. And so it's really important that they understand this, and this may be an area where you'll need to provide some patient teaching now, or some education for them. Now, one of the things that I get asked a lot is how long should you do a bladder diary for? And understand that the longer the bladder diary goes on, the less accurate it is likely to become, because it's difficult for people to keep that up. Ideally, it's nice if you can get 3 days, 3 consecutive days. This gives you a snapshot, and it's complete, and it's really very, very helpful. Sometimes we're not always able to do that with patients. Sometimes we can only get a day, and I will take that, but my preference is to have 3 days. And if it's a facility that's really, gets it, the value of these bladder diaries, and the CNAs understand their role, oftentimes I can get 5 complete days, which really gives you a nice picture of what's going on with that resident. Now, another tool that we can use to determine bladder emptying is using a bladder scanner. So I want you to also find out whether or not your facility has a bladder scanner, and if they do, being able to spend time looking at the instruction manual. They usually do a very, very nice job of nurse education tools, of user education tools, so that you get a really good sense. There's oftentimes case studies included so that you can think about the types of patients that you would use them, and many times there's videos that are involved. And so I want you to set some time aside to find out whether or not your facility has a bladder scanner, and if it does, being able to review the resources that came with that so that you can use that tool more effectively in your practice. Now, some sites don't have a bladder scanner, and they are expensive. They're about $10,000, and so not every facility is going to have one. And so this is an example of where if you have concerns about bladder emptying, this is an example of where it would be important to have someone empty their bladder to the extent that they're able, and it's nice, really important that you're able to catch that in the hat so that you can measure it, and then straight cath them to see how much urine is left in the bladder. Now, what's nice about the bladder scanner is we don't have to insert anything in the urethra, and we can capture that same information, not only the voided amount, but also how much is left using the scanner. And in addition, monitoring for signs and symptoms of incomplete bladder emptying, and this is the urgency, the frequency. You just took them to the bathroom and their light's on again. They get recurrent urinary tract infections. Assessing for emptying is going to be a really important part of your assessment piece for that. Physical exam, incontinence is pretty complex, and so there's lots of things that you need to look at. You need to look at their cognition, their ability to recognize when they need to toilet, as well as their mobility. That's their ability to be able to do it and manage their clothing. Their function, are they able to take care of, their day-to-day activities, or do they require help? And then another part that I see nurses not really doing all that often, and it's certainly within the context, the scope of your practice, and that is an abdominal exam. Because if somebody's constipated or has bladder distension, you will be able to potentially feel something on abdominal exam. Also, being able to do a urogenital exam. I see this deferred almost all the time on the admission physical, and it's really important that nurses are going in, taking a look at the condition of the skin in the genital area. And for women, they're going to see signs of estrogen deficiency. They might have some thinning of the skin, the labia, they might have some retraction of the urethra. The vagina itself might be either red or very pale and narrowed. And so it's important to be able to take a look at that. The urethra, oftentimes, if it's not pulled up inside the vagina, the urethra will actually be somewhat gaping or open. And that's an issue that needs to be treated also, because that tells you that there's significant estrogen deficiency. You can also observe whether or not there's been any structural changes. And so the structural change that we get the most concerned about is whether or not there's been enough relaxation of the pelvic floor that the pelvic organs are starting to fall down or prolapse into the vagina or move to the outside of the body. And this can happen with the bladder, it can happen with the uterus, and it can happen with the rectum. So again, this is something that if you're observing that, definitely needs to be referred for further evaluation. And then pelvic floor muscle weakness. Pelvic floor muscle weakness can be easily assessed by just inserting one finger just inside the opening of the vagina and asking the woman if she, first of all, can feel that, and secondly, if she's able to contract her muscles around your finger. And what we see a lot with people in general is they're able to contract their buttocks, they're able to contract their thighs, they're able to contract their abdomen, but they aren't necessarily able to isolate their pelvic floor muscles. And so one of the ways that I teach that is I ask them to think about a social situation where they have to pass gas. So they might be in a party, they might be in an elevator, they might be, ready to shake hands with the minister at church, and all of a sudden they have to pass gas. And so typically what people do is they tighten their rectal muscle. And so by tightening your rectal muscle, that actually will help them isolate the pelvic floor muscle, that grouping, a little more easily. And you do want to be able to contract and release a series of exercises, which I'll go into in a minute, over time. So rectal exam, also an important thing, particularly for tone, but also whether or not stool is in place. And for men, this is also how you can determine whether or not the pelvic muscles are weak. And then again, a neuro exam. Do they have a sensation? Do they have lower extremity reflexes? All of that comes into play. So to determine the type of incontinence, you want to take a look at their history. So what are their bladder symptoms consistent with? What other chronic illnesses or risk factors do they have? What's their social and cognitive status? And what medications might be putting them at risk or causing their incontinence? And on the physical exam, you want to be able to use a bladder diary to assess their pattern and their frequency. And you also want to ensure that their bladder is emptying. And then doing a focused physical exam, again looking at mobility and function. An abdominal exam, a urogenital, and a rectal exam would be important. I also look at the extremities to see whether or not there's peripheral edema, because these patients are going to be more at risk for nocturia or incontinence at night when they finally are able to lay down in bed for 2 or 3 hours. That whole diuresing effect will increase their risk of incontinence. So, how do you put the plan together? Well, this needs to be individualized, and nurses can most certainly implement behavioral interventions. And those interventions can include toileting regimes. It can include exercises to inhibit the urge, as in overactive bladder and urge incontinence. It can also include retraining, especially after having a urinary catheter in. How you use your fluids, how you manage fluids, and what kind of bowel plan is in place to address constipation. Also, your plan of care can discuss how to preserve mobility and function. So walking, toileting, core strength is going to be really important. Is this a resident who might benefit and is motivated to do pelvic muscle exercises? You do need to be cognitively intact to be able to do the steps of pelvic muscle exercises. So this isn't going to work for everybody, but certainly continuing to keep all of our residents walking as long as possible and engaged in toileting, as well as maintaining core strength, is going to be an important alternative to that. And then interventions to treat and manage other contributing factors. So, is their clothing manageable? Is their environment make the toileting accessible? Do they need any assistive devices, such as an elevated toilet seat or a grab bar? And then if they do need to use an absorbent product, is the right product for the amount of urine lost appropriately selected? Because I oftentimes will see this as an issue where someone's given a brief when in fact they could have been in their own underwear with a pad, so that they could feel like their function was more normal. And again, that's less cost to the resident and to the facility also. So toileting regimes can be independent, scheduled, prompted, or social continence, and we're going to talk about each of these. And in order to be able to engage in independent toileting, you need to be able to toilet yourself. You need to be able to manage your clothing, and you need to be able to manage your hygiene. And your ability to do all these things makes you confident of your bladder function in social situations. Now, sometimes we'll see an older adult who can do those first three things, but has maybe had a situation where they've had an accident. And so this is when they'll want to add an absorbent product in a social situation. And that's a really appropriate use of an absorbent product in this situation. Scheduled toileting, or sometimes called habit toileting or habit training, the idea behind scheduled toileting is to find the schedule that will support dryness. So again, using your bladder diary to determine somebody's schedule and trying to, follow that schedule. Usually people need to empty their bladder every 2 to 3 hours. I mentioned that sometimes for some of our older adults it's a little more frequently than that, but it's an important thing to just kind of keep in mind and to kind of know what their schedule is. It's also a good example of where the bladder diary should be capturing those patients who require more toileting assistance in the morning after diuretic use than at other points of the day, and that you're able to tailor your plan of care by recognizing that and having assistance available to them. And then finally, the scheduled toileting should reflect the resident's routine and activities, not the nursing homes or the nurses. So whenever that resident gets up in the morning, whenever they're done eating, whenever they take a nap, whenever they go to bed are typical times. Prompted voiding not only recognizes their voiding habits, but also gives positive reinforcement for continence behavior. And this is particularly effective in people who have cognitive impairment. And so mild dementia is one of the areas that frequently comes to mind. And in this situation, it's really important that they trust the caregiver, that they know who the caregiver is and that they trust them, because then they'll relax and they won't be so worried about it. And as the caregiver, it's important to remind them that you're on a schedule. And so one of the ways you can do that is you can say, well, remember you just went about a half hour ago, so let's give it another half hour, 45 minutes, and then if you feel like you need to go, I'll take you again. And again, that reassurance, and then assisting them as needed, positive reinforcement, particularly when they've put their light on and they're recognizing it and you can get in there and get them toileted, giving them a lot of positive feedback for their ability to let you know. And then reminding them when you'll be back is another component to prompted voiding. Social continence is one of the toileting plans that we really reserve for residents who are sort of at the end stage of their life or their disease processes. And so this is a situation where they have they've just developed incontinence to the point where they might not even have an awareness of when they're losing urine. And so we call that intractable incontinence. And sometimes what I hear, not sometimes, a lot of times, I'll hear people refer to that as check and change. And I would really encourage you to not use that language, because check and change does not really support dignity and quality of life. It kind of infantile, it's kind of a try to say the word here. It lends reference to being a baby or an infant again, and that's not the situation. What we're really doing with social continence is we're focusing on dignity. And so part of social continence is keeping them dry, keeping them odor-free, keeping their skin in good condition. And that is a very important thing for not only the resident but also their family and caregivers. And so I would encourage you as nurses to just move beyond this language of check and change, which is perceived as somewhat degrading, and being able to have a conversation with the resident and the family that I know your incontinence has really progressed, and I just want you to know that our plan of care for you is to help you stay socially continent. And what that means is we want to keep you as dry as possible, odor-free, comfortable with your skin in good condition. And that is very, very reassuring and respectful to not only residents but also to their caregivers. I've put a link on here to the National Quality Performance Standards for Disposable Adult Absorbent Products for Incontinence. This was released in 2012, and this comes out of the fact that there are a lot of companies out there that are attempting to make money off of inferior products. And so the National Association for Continence developed quality performance standards, and so this might be something that you would be interested in sharing with your facility. Bladder retraining requires a resident to be cognitively intact, and this works really well with urgency and frequency. The idea is that you're using pelvic muscle exercises to avoid rushing to the bathroom. And so when you get the urge to go to the bathroom, you stop, you take a slow, deep breath, and you start to say things to yourself like, this can wait, it's just not time yet. And at the same time that you're doing this, you're isolating your pelvic floor muscles, and you're doing what we call several quick flicks, usually 5 or so quick flicks in a row. And you contract and release and contract and release and contract and release, and do that 5 times. And what that does is it settles down the bladder. And that person can then start to walk towards the bathroom. Now, if that urge comes again, you do the same thing. And you continue to repeat that process until that person does gain better control over the urgency and the leaking. And it can take about 3 to 6 weeks depending on the amount of muscle tone that somebody has. But this is something that will occur, and improvement is gradual, but it does happen. And for many residents who are cognitively intact, they really want to try this first instead of adding another medication. Or they want to try this in addition to a medication. So again, a really important tool to have.